was asked to speak about inflammatory markers and what they mean and why do we send them and what's the indication, etc. So there really are, there's a whole series of inflammatory markers. The most common ones are what we call acute phase reactants. So acute phase reactants are things that in general increase or decrease by 25% in response to inflammation. So the ones we think about are white blood cell count, platelets, sedimentation rate. These are all acute phase reactants. So they change in response to any inflammatory stimulus. So the problem is they don't differentiate between infection and inflammation. So they're limited in their ability to differentiate the cause, but they're good at following the inflammatory response, and when that inflammatory response has gone away, they tend to normalize. So we use those all the time, whether you know it or not, white count being one we use a lot. Probably more recently, what we started to use are other inflammatory markers, some that we rarely send in your average patient, but send to certain types of patients, things like cytokines. So you guys may have heard of like interleukins, interleukin 1, interleukin 6, interleukin 10, or tumor necrosis factor. These are things that are sent clinically in certain patient populations to look at inflammation. But I would say, at least in my experience, they're more often used experimentally or in research studies. They're not so much used clinically. And part of the reason is because a lot of the cytokines and other inflammatory markers vary depending upon your age, your gender, so they're different in men and women, and your race even. So if you don't have a series of norms to compare them to, they don't do you a whole lot of good. So I think you use them in, like I said, very sophisticated assays in a research lab when you're doing it for a specific clinical research study or trial or something, but we don't tend to use them a lot clinically. And that's really kind of the problem with inflammatory markers in general, is if they're not easy to follow and interpret, if you don't have a whole good set of norms to compare them to, if they vary between lab and lab, which a lot of them do, so there might be different norms here at the University of Michigan than at DMC, so people work both places, it means different things. Those that variability in measuring inflammatory markers makes a lot of those very impractical. So the two that we end up using clinically the most probably are C-reactive protein and procalcitonin. And those are the ones you guys are seeing nowadays. And I think it's important to understand the differences because that tells you when to send them and what they might indicate. So C-reactive protein is a it's a good study to detect inflammation or ischemia and necrosis of any cause. And it can be in any organ. So it's a serum protein that increases in response to inflammation. And normally, if we're just sitting here, we have very little C-reactive protein, like 0. And the scales that they use is generally like less than 0.5. And when you have inflammation, it doubles or triples or quadruples. So it goes up quite a bit. And so you can really compare that to a good set of norms where there really shouldn't be any inflammation. It's a fairly sensitive test. It doesn't differentiate between inflammation and infection, which is often what we care about. It is not as age dependent as some of the other inflammatory markers I mentioned. And it's a good way of sort of monitoring response to therapy. So if you knew someone had a massive inflammatory response for whatever reason, and you could see their C-reactive protein was increased, and you gave them an anti-inflammatory drug, like a steroid or something, you should be able to see that come down and monitor when it has effectively decreased inflammation. It's an easy test to run, it's cheap, so in that sense I think that's why you see it sent a lot. The problem with it is that it doesn't really go up until as early as 6 hours and as late as 12 hours after whatever the insult was. So in our patient population, oftentimes the insult is cardiopulmonary bypass. So you will see that C-reactive protein will go up 6 to 12 hours, even as late as 24 hours after bypass run. And that'll signify how much the patient has responded to that bypass with an inflammatory response. And then it'll stay up for a period of time, as much as 24, 48 hours, and then it'll start to come back down. So it's sort of a slow responding, sustained high, and then a fall. Whereas procalcitonin is a better marker to do two things. One is differentiate between inflammation and infection. It goes up in both, but it goes up to different degrees for inflammation and infection, and specifically bacterial infection. So at the University of Michigan, for instance, normal for a procalcitonin is between 0 and 0.05. So very little, almost 0. Says you don't have any inflammation, you don't have any infection. Between 0.05 and 0.25 says you have an intermediate inflammatory response or infectious response. The likelihood is that you have a bacterial infection. Between 0.25 and 0.5 is highly likely that you have a bacterial infection, and greater than 0.5 is like you have a definite bacterial infection. And again, it is differentiating between viral and bacterial, so it's really useful in the ER, for instance, when kids come in with respiratory symptoms. Is it bacterial or is it viral? Inflammation can still raise it, but it doesn't raise it necessarily to the same degree. In response to bypass, both procalcitonin and C-reactive protein, as I mentioned, will go up in response to inflammation without an infection. But procalcitonin will go up faster, it'll stay up for a shorter period of time, and then it'll start to normalize, usually within 24 or 48 hours. So after that first couple of days after bypass, if you had an elevated procalcitonin 3, 4, 5 days after bypass surgery, you can be pretty sure it's an infectious problem. So it's a very good marker, and it's now, you guys have seen it on the internal web page, it is the recommended biomarker to detect bacterial infection in anybody. And the scale is pretty similar whether you're an infant or whether you're an adult. So that, again, that's sort of 0 to 0.05, negative, 0.05 to 0.25, possible, 0.25 to 0.5, likely, greater than 0.5, highly likely, or definite, however you want to say it. So we often send both the C-reactive protein and the procalcitonin to assess an inflammatory response and hopefully to differentiate between an infectious response and an inflammatory response. The C-reactive protein, because it stays up longer, is nonspecific, you're more likely to catch it being high. The procalcitonin will be more specific for the bacterial infection and should start to normalize. Probably the most useful thing for both of them is to use them to monitor therapy. The length of therapy and the effectiveness of therapy. So if you had a patient who you thought had stenitis, the procalcitonin should be high. You put them on antibiotics. If it's really treating them, not just should their fever come down and their white count normalize, the procalcitonin should start to come down to normal faster than those other things would change and normalize. So it's a good monitor of therapy. So those are the two you'll see sent the most. It used to be, when I started medicine, the SED rate was the common thing that we'd send all the time. And that's not even as good as a C-reactive protein in terms of sort of sensitivity, specificity. It's just elevated no matter what. If you have rheumatoid arthritis, it's elevated. If you have tuberculosis, it's elevated. Anything that causes any kind of inflammation. So I think with a combination of procalcitonin and C-reactive protein, we can pretty much, especially with clinical cues as well, we can pretty much diagnose whether someone is having an inflammatory response or an infectious response, and then treat them accordingly and monitor their response to therapy. Does that make sense? So what questions do you guys have? Are there other things that you've seen sent that you're curious about? I think those are the two that I've seen sent most frequently nowadays. Is that helpful? Does that make sense?
Mm-hmm.
Yeah.
So I think probably from the nursing perspective, if you suspect somebody of having a bacterial infection, again, out of that 1 to 2 days of having their bypass, because there you can't really tell, I would make sure that you encourage the house officers, the fellows, whatever, to send a procalcitonin, because it could be very useful. In Michigan, they recommend never diagnosing a bacterial infection by procalcitonin alone. It's supposed to be a combination of, a fever, elevated white count, plus a procalcitonin. Other signs there's something there. Because it is true that most of the studies have been done in adults, not kids. And so it isn't, we don't even really know how truly reliable it is, especially in young kids. So they want to have a constellation of findings in addition to procalcitonin being elevated. But I think the other important thing is to make sure that you check it daily or so to really monitor the response to therapy. Because if you had patients that were resistant to antibiotics, for instance, selecting out for some abnormal bug, and we don't grow cultures, for 2, 3, 4 days sometimes. You should be able to see whether or not you're effectively treating it. And I think that's probably one of the more important things. We don't do that routinely, I don't think, or not enough anyway. So I think it's useful from that perspective. Anything else?
Would immunizations affect that?
Not that I'm aware of. The C-reactive protein will go up with immunizations, I'm sure, because it goes up with chest closure. So, if you just had somebody going through a routine delayed sternal closure, there's one study I saw that all the C-reactive proteins went up, but the procalcitonin don't. So again, I think of it as a more sensitive marker for the infection part. So I'm sure that an immunization, which causes at least a local inflammatory
Right.
response, would raise your C-reactive protein. Just like it can give you a fever. Same thing.
Okay.
Other questions, or pretty short and sweet? Not much of cardiology, but what can I do?
That's good though.
All right.
Yeah.
Good. There.